So moving on to the next slide. Okay, now there are multiple causes to depression. Okay, for example, you can have depression as a result of getting a virus or viral infection. We know there's a disease that's called Borna disease, which happens in people who live on farms. And when we look at these people, we discover that their depression is as a result of this virus. In fact, a third of people with severe depression or schizophrenia, when we test them, we find that they're positive for this virus. And they don't need treatment for depression, they need treatment for the virus. Okay, again, multiple different causes for depression. Okay, so let's move on to the next slide to really make that point home, is that depression is heterogeneous. There are many different causes for depression. We talked about genes, we talked about a brain story, we talked about early trauma story, we talked about hormonal imbalance, we even talked about virus as a cause of depression. And also in literature recently, there is talk about inflammation and treating depression as an inflammatory disease. So depression is a heterogeneous disorder and phenomena. Thus, treatment should also be equally heterogeneous. Okay, so let's jump right into treatment by going on to the next slide. Let's talk about antidepressants, okay, or oral drugs. There's many drugs to treat psychiatric disorders, and a lot of them were discovered by accident. Here are the categories or the family of antidepressants. We have what's called tricyclics, SSRIs or selective serotonin reuptake inhibitors, monoamine oxidase inhibitors or MAOIs. Chances are, if you have a medication in your pharmacy, it probably says don't take if you're taking MAOIs. And then some what's called atypical antidepressants. Tricyclics, basically what they do is they block the recycling process of some of the important chemicals that we think are depleted in the depressed brain. And fortunately, though, they also block other unrelated chemicals, leading to some undesired side effects like drowsiness, heart irregularities, and dry mouth. Selective serotonin reuptake inhibitors, which is very commonly used as probably the #1 family when looking for treatment for depression, also blocks the recycling of some of these chemicals, but it focuses on serotonin as the main chemical. It blocks its reuptake, meaning it increases levels of serotonin in the depressed brain. And works in a very similar fashion to tricyclics, but it has less mild effects. However, it has the same effectiveness. It just has milder side effects. Nonetheless, it does have its own side effects. So moving on to look at other antidepressants. Some very newer drugs on the market, are related somewhat to SSRIs, are called serotonin and norepinephrine reuptake inhibitors. So here, it focuses on increasing levels of serotonin and norepinephrine in the depressed brain. So you might have seen ads in the recent years for what's called Cymbalta as antidepressants, and this will increase levels of both serotonin and norepinephrine in the brain. Okay. Moving on to look at the other category of antidepressants, what's called monoamine oxidase inhibitor. This family of drugs inhibits the enzyme that breaks down some of these important chemicals, making these chemicals serotonin, norepinephrine, and dopamine, increasing their levels in the brain. Unfortunately, though, this should be used or prescribed only if SSRIs, selective serotonin reuptake inhibitors, and tricyclics are not effective, because you have to avoid eating a lot of different foods when you're taking to this medication, because it can lead to some serious medical conditions. Now moving on to look at what's called atypical antidepressants, which is basically a group of antidepressants that don't affect serotonin, but they affect other types of chemicals, and they happen to improve mood as well. So for example, Wellbutrin, which maybe you have heard of Zyban before as a medication for smoking cessation. Well, it turned out that it didn't just stop smoking, but it also made people feel better, and now has been marketed under many different names with antidepressant qualities. And going on, now I'm not sure what country most of the attendees are from, but in the United States we have an agency called FDA that regulates foods and drugs, but it does not regulate herbs. So one herb that's called the St. John's wort is also an herb that has shown antidepressant qualities. However, though, if taking that herb, don't assume that just because it's a plant, that it's just generally good. And you can consume as much as you want, because it will interact with the effectiveness of other drugs. For example, it'll interact with things like birth control, with things like AIDS medication, and other antidepressants. Now, going on to the next slide, we learned that there's a problem with the logic used of antidepressant oral medication. And that is, most people with depression have normal levels of neurotransmitters, we talked about, serotonin. And also, decreasing serotonin levels in people who don't suffer from depression, supposedly, if this hypothesis is correct, it should make them depressed. But it doesn't make them depressed. So what's going on there? And also, when we give a drug, an antidepressant drug, so if you've experienced, depression and have taken oral medication, you might have noticed that you had to take the medication for weeks before you actually experience any mood elevation. Even though if we look inside your brain, the neurotransmitter, serotonin, for example, has already increased minutes to hours after taking the medication. So what's going on with this lag? Why does it take such a long time? Okay, going on with the list of problem with the logic of effectiveness of antidepressant medications. So going on to the next slide, yeah. This effectiveness is limited, and sometimes even without antidepressants, people just seem to get better. And with antidepressants, there's a huge placebo effect, okay, which we'll show in the next slide. I have a beautiful picture of that. And also, people who suffer from depression don't all respond well to antidepressants. Only about 30% respond well to antidepressants. So here I'm showing a picture that comes from a huge meta-analysis study that looked at a huge number of studies comparing antidepressants to a placebo. So basically, placebo is basically a sugar pill, but the person doesn't know they're taking a sugar pill. They don't know if they're taking an antidepressant or sugar pill. On the x-axis, I have the severity of depression. On the y-axis, I have improvement. Did that pill work or not? The red shows the drug, the group who's taken antidepressants. The dashed blue is the placebo group. Now, you don't get to see the start of any clinical significance, meaning that the drugs were very effective, until you get to very severe ratings of depression, 28 or up, so that green shaded area. Meaning that for mild or moderate depression, the placebo group was just as good as the antidepressant group. Now, I can tell you that the pharmaceutical companies didn't really like that study that much, to say the least. Okay, so that brings us to what else is out there other than antidepressants.